colleagues online, good evening. Welcome to the 14th live broadcast of the Guardian series. Hello, distinguished experts and colleagues joining from all over the world. Welcome to the 14th session of our Guardian live broadcast series. I'm your old friend Liu Mingguai. I'm from Shanghai Kobe Life Medical Technology Co., Limited. First of all, on behalf of the event organizer, to all the experts and colleagues online, I'd like to extend a warm welcome and sincere thanks. At the same time, to all the partners of this live broadcast, technical support team, and backstage staff, I would like to express my heartfelt thanks. Hello everyone, I'm Rose Liu, the director of Shanghai Shenwu Intelligent Medical Technology Company. It's our great honor to connect with so many professionals from China and abroad. Where this live platform, today we will focus on the clinical application of Intraop2 neuromonitoring in neurosurgery, share practical clinical experience and technical essentials, and conduct in-depth academic exchanges. Hope this live stream can bring you valuable inspirations and fresh perspectives. Thank you very much. This live broadcast is simultaneously on the Electrophysiology and Joint Innovation Center video account and Kobe Kishong video account, as well as domestic live streaming platforms and overseas simultaneous interpretation platforms. Colleagues at home and abroad can watch it simultaneously and discuss it. We sincerely thank our organizer, Shanghai United Electronics and Rehabilitation Technology Innovation Research Center, for their long-term support. The platform continuously builds a communication bridge for industry, academia, research, and medical care, helping the innovative development and clinical implementation of neuroelectrophysiology technology. We also thank our co-organizers, Nuocheng Electrophysiology, for their full collaboration. The company has been deeply involved in the field of neuroelectrophysiology for many years, providing professional products and services to safeguard clinical monitoring. We also want to thank the Brain Medical Platform for their great support as a high-quality academic platform in the field of neuroelectrophysiology, which continuously connects global colleagues, spreading cutting-edge ideas, sharing clinical experience, and enabling high-quality academic resources to reach frontline healthcare workers widely. Together, we have built this professional online academic salon. This salon mainly focuses on intraoperative neuroelectrophysiology monitoring, the core topic of. Next, we are honored to have the neurologist Dr. Shi Hong from the First People's Hospital of Anning, Yan University of Science and Technology, to join us in this live session. Now, let me briefly introduce Dr. Yang.
Hello, everyone.
Dr. Yang Hai Yang is the director of the Department of Neurosurgery at the First People's Hospital of Anning, Yunnan University of Science and Technology. He holds a master's degree in medicine and is an associate chief physician. He is also a member of the tumor branch of the Kunming Medical Association, a long-term care insurance assessor in Kunming, a member of the Second Stroke Professional Committee of the Yunnan Private Hospital Association, a member of the Stroke Prevention and Control Professional Committee of the Yunnan Preventive Medicine Association, a member of the First Committee of the Brain Function Testing and Regulation Rehabilitation Professional Committee of the Yunnan Rehabilitation Medicine Association, a member of the Third Private Hospital Branch of the Yunnan Hospital Association. In terms of diagnosis and treatment, it is good at microsurgery for brain tumors and intraspinal tumors, endoscopic surgery, and interventional and microsurgical treatment for various craniocerebral injuries, intracranial aneurysms, arteriovenous malformations, and ischemic cerebrovascular diseases, resistant epilepsy, trigeminal neuralgia, facial spasm, Parkinson's, movement disorders, and individualized surgical treatment for some functional neurosurgical diseases. The stance direction is the integrated diagnosis and treatment of cerebrovascular diseases and nervous system tumors, as well as the molecular pathogenesis of cerebrovascular diseases and brain tumors. He has published more than 10 core journal papers at home and abroad as the first author or participant, and is committed to microsurgery for brain tumors, cerebrovascular diseases, and craniocerebral injury, as well as the research of interventional therapy for cerebrovascular diseases in neurology and neuroendoscopy surgery. Dr. Yang has been deeply engaged in the front line of neurosurgery for many years and has very rich surgical experience and clinical management experience. In various complex neurosurgical surgeries, intraoperative neuroprotection, and the application of electrophysiological joint monitoring, we have unique insights and profound experience. Now, let's give a big round of applause to welcome our special host, Director Yang Haiyang, to give the opening remarks.
Thank you to the host. Dear colleagues, good evening. I am Wu Wenrui, a doctor from the Department of Neurosurgery of the First People's Hospital of Anning, Yan'an University of Science and Technology. It is my great honor to welcome all the experts and colleagues who have taken time out of your busy schedule to participate in this academic exchange. Neurosurgery, especially high-risk surgeries involving cranial nerves, strives to strike the right balance between tumor removal and nerve protection. Real-time and objective electrophysiological signals provide surgeons with dynamic information about lesion location and nerve function, significantly reducing the risk of surgical nerve damage and improving outcomes. Today, we have specially invited Sujing Cheng, an electrophysiologist, to share with us the intraoperative neurophysiological monitoring and its clinical applications in neurosurgery. Sujing Cheng has been deeply involved in intraoperative neurophysiological monitoring for many years, and he used to be my colleague. Now that I've moved to a new unit, he has followed me here as well. We have collectively completed over 1,000 cases of neurosurgery monitoring, and I hope all of you will speak freely and engage in active communication, sharing the problems and accumulated experience encountered in clinical work for discussion. Let's work together to promote the standardized application and development of neurophysiological monitoring technology in the region to better serve patients. Finally, I wish this academic exchange activity a complete success and wish all colleagues gain something from it, work smoothly, and stay healthy. Thank you all. Let me briefly introduce Dr. Sujing Cheng. He has worked in Capital Medical University, Sambo Brain Hospital, Yunnan Second People's Hospital, specializing in neurophysiological monitoring. He has long worked in Kunming Sambo Brain Hospital, and now he is also working with me in the Second People's Hospital, affiliated to Kunming University of Science and Technology. He has long been dedicated to intraoperative neurophysiological monitoring, the entire process of intraoperative monitoring in neurosurgery. He is good at monitoring brainstem tumor resection, spinal cord tumor, and intraoperative EEG monitoring for functional neurological diseases such as epilepsy. Neurophysiological monitoring has been performed in over 1,000 neurosurgery cases. The accuracy rate of intraoperative monitoring remains above 95%, and I have extensive clinical experience. In the following time, I will mainly give the floor to our electrophysiologists, because today we will mainly discuss intraoperative neurophysiological monitoring. We warmly welcome technician Sujing Cheng.
Okay, let's welcome Mr. Su.
Can you hear me, everyone?
Yes, we can hear you, Mr. Su.
Okay, let me share my screen.
Thank you very
The anecdote. Director Yang is very busy, and he has to go to the emergency for an aneurysm surgery soon. I would like to thank Mingwei for providing us with this opportunity for online exchange and learning. It's not easy for everyone to get together and learn in the same room. Through online learning, Our monitoring technology has been improved to varying degrees. I replayed all the previous episodes that I missed, and I think this model is very good. Let's get started. Today, we will mainly talk about intraoperative neurophysiological monitoring, some applications in neurosurgery. When talking to patients, when surgery is about to be performed, many patients will ask that there are many important nerves in our brain, blood vessels, and whether there will be damage during the operation. Once damaged, can we still hear, be paralyzed, or talk normally? These are all issues that patients are very worried about, but currently, we can apply electrophysiological monitoring technology to address most of them. Today, I will mainly discuss from the following four aspects the application of electrophysiological monitoring in neurosurgery. The first is the concept of intraoperative electrophysiological monitoring, the purpose of monitoring, and the current monitoring methods used in surgery, then different surgical electrophysiological monitoring methods, and the concept of electrophysiological monitoring, as those of us working in this field all know, is to use various electrophysiological techniques to monitor the integrity of the nervous system function during surgery. When it comes to electrophysiological monitoring, we have to talk about the development history of evoked potentials, because all the monitoring techniques we apply now are derived from evoked potentials. In 1975, our British scholar Richard Catton first discovered the passage of direct current in animals, and then in 2024, German psychiatrists discovered that the human brain also has similar electrical activity and published many related papers. Then in 1933, Nobel Prize winner confirmed the conclusion of the German psychiatrist, officially forming the theory of EIG. However, the Nobel Prize winner found on the scalp that the amplitude of EIG recorded on the scalp is only 30 to 100 microvolts, and the evoked potential is even smaller, only 0.3 to 20 microvolts, which is difficult to record. American scholars use signal superposition technology to solve the problem of somatosensory evoked potential, and in the 1960s, with the development of computer, the technology of evoked potential became more advanced. So some of the monitoring technologies we currently use, as we all know, all evoked potentials cannot be separated from the technology of superposition, and the history of intraoperative monitoring dates back to the 1960s. Firstly, in acoustic neuroma, we monitored the facial nerve, and in the 1970s, somatosensory evoked potential was applied to scoliosis surgery, and in the late 1980s, our BAP, brainstem auditory evoked potential, was applied to microvascular decompression surgery, which is what we call hemifacial spasm, trigeminal neuralgia, glossopharyngeal neuralgia, and other diseases. In the late 1980s, our electromyography, EMG, and BAP brainstem auditory evoked potential were applied to skull-based surgery. Then, in the 1990s, the motor evoked potential was also applied to spinal lesion surgery. Now, brainstem surgery also requires MEP as an essential monitoring method. The purpose of electrophysiological monitoring is to identify neural damage caused by surgery in a timely manner so that intervention can be taken immediately and specific neural structures can be identified anatomically to ensure that the nerves are not damaged, and to identify the neural structures that have lost their function during the operation, helping the operator to adopt a more active surgical strategy, such as the resection of tumors and epileptic foci, and also to help analyze the surgical operation of nerve damage and improve surgical techniques and skills. It can also predict the recovery of postoperative nerve function and monitor the impact of systematic changes on nerve function during the operation, such as some drugs, ischemia, hypoxia, hypotension, and nerve damage. Currently, the main methods of electrophysiological monitoring are as follows. The first one is the intraoperative neurophysiological monitoring, which is inseparable from evoked potentials. The first one is somatosensory evoked potential, then motor evoked potential, brainstem auditory evoked potential, BAEP, and EMG. All of our surgeries, whether neurosurgery, spinal surgery, all rely on the superposition of these techniques to monitor the integrity of neurofunction during surgery. Let's take a closer look. The key points of these monitoring methods. The first one is CSEP. It can be used to monitor the integrity of the deep sensory pathway because the signal of SSEP is relatively easy to obtain, and it is one of the earliest technologies applied in intraoperative monitoring. In spinal cord and spine surgery, brainstem tumor surgery, and cerebrovascular surgery, it plays an irreplaceable role. CSEP can be divided into upper limb SSEP and lower limb SSEP. You can see these three waveforms. From bottom to top, the black one is the first waveform of SSEP, which is recorded at the point. The green line in the middle is the nerve root, which is recorded at the cervical spine process. The red one is the waveform recorded in our central nervous system. Here is the cortex, which is recorded at C3, C3, and C4. The recording points for the upper limbs include some teachers who come to our unit for further study. Beginners ask what C3 and C4 are and what the top 20% of C9 is. Speaking of which, we have to talk about the 10 to 20 system EEG. So at the beginning, our unit, when learning intraoperative EEG monitoring, first of all, we need to learn how to apply EEG. Only after that can you understand where these potentials are and what they mean. For example, FZ, CZ, C3, C4 are all closely related to the international 10 to 20 system. When stimulating the left side, we apply electrodes on C4 to record the data, and FZ is used as a reference. Why? Because those who have worked outside of Zhejiang know that, or those who are in charge of monitoring know that, our brain is contralaterally dominated. The left side dominates the right side, and the right side dominates the left side. That's how it works. As for the lower limb somatosensory evoked potential, we also apply electrodes in the popliteal fossa, which is the posterior cervical nerve, to stimulate it. Then we have a recording point in the popliteal fossa to record the surrounding nerves, and then we have a recording point at L1 to record the nerve roots, and then we have a recording point at central CZ to record our central nervous system. As everyone just mentioned, look at this model of the brain. Why does it need to be delayed by 20% or 10%? It is based on our international 10 to 20 system EEG for positioning. Then look at the recording point of our head for the lower limbs. We record at CSC. For reference, we also make a reference at FC. Then the green electrode is a record of our lower limb somatosensory. The red one is our upper limb. The red and yellow one is a record of our upper limb somatosensory. Then the stimulation is on the posterior nerve of the lower limbs. For the upper limbs, it is on the medial nerve of the occipital. Here, we must distinguish well which is the cathode and which is the anode. We must distinguish them because for some people who are just starting to work on this, if they don't distinguish between the cathode and the anode, the image will not turn out well. We need to pay attention to the somatosensory evoked potential mapping. It reflects the function of the posterior column sensory pathway. It does not reflect motor function or root function. We need to combine with other monitoring modes and make a comprehensive evaluation. In other words, in a surgery, we cannot just use one technology to monitor the surgery. We need to use multiple monitoring methods to jointly determine whether the nerves or spinal cord functions are affected. If we only use one monitoring mode to monitor the surgery, the false positive rate will be very high. Then for the influencing factors of SEP, besides environmental factors, it is also affected by anesthesia, body temperature, blood pressure, limb ischemia, and improper limb position. During monitoring, we should pay close attention to the patient's vital signs and make accurate judgments. This means that while we are monitoring, we must know which anesthetics cannot be used in the monitoring mode today, which is of utmost importance. If you don't communicate with the anesthesiologist in advance and he uses some medicine, then you won't be able to see anything during the operation. Eventually, it may lead to nerve or functional damage, which is unnecessary. Therefore, when using each monitoring method, we must know which monitoring and anesthetics cannot be used, which is very important. Then there is the third point. In the surrounding neuropathy, such as diabetes and long-term diabetic patients, because everyone knows that an important complication of diabetes is to cause damage to our peripheral nerves. Preoperative somatosensory evoked potential will be abnormal, which will affect the evaluation of the function of the entire nerve pathway. It is recommended to do neurophysiological monitoring before surgery. If intraoperative monitoring of somatosensory evoked potential is needed, it is best to do an electromyography before surgery to see what the situation of his somatosensory evoked potential is, because the patient is relatively easy to control before surgery without strict requirements such as anesthesia and body position. It can help us better evaluate during surgery. In monitoring, the main observation indicator of somatosensory evoked potential is the amplitude, which is different from the routine examination in the laboratory. In the latter, we mainly focus on the abnormality of the latency period, while during the operation, we mainly observe the abnormality of the amplitude. If the monitoring of the somatosensory evoked potential is inconsistent with the waveform of the preoperative somatosensory evoked potential, and if you have done the preoperative examination and the CAP examination is inconsistent during the operation, then you can rule out some intraoperative conditions, such as the surgeon inhaling too much after anesthesia, or the amount of stimulation in a relaxed state is greater than usual, and then after some anesthetics are inhibited, the waveform cannot be differentiated, which requires a complete evaluation. As mentioned earlier, we need to do an intraoperative evaluation so that we can better assess. Otherwise, if you don't do it under the microscope and find a problem, the SEP will not show a wave or the waveform is very poor. Then you cannot judge at this time whether it is the patient's own problem or your own technical reasons for the operation or some impact of anesthesia, because it is impossible to wait for you to keep investigating during the operation. The operation also needs to be carried out. Then let's talk about the monitoring of motor evoked potential. The monitoring of motor evoked potential is that we stimulate the motor area of the cerebral cortex, or the spinal cord, and record different kinds of potentials at different levels of the peripheral nerves or skeletal muscles of the spinal cord, to achieve the purpose of monitoring the conduction pathway function. And the motor evoked potential monitoring technology used in clinical practice currently mostly applies transcranial electrical stimulation motor evoked potential, which is to give electrical stimulation to the motor area of the cerebral cortex outside the skull, activating the corticomotor, and then the excited electrical signal travels down to the motor neuron, causing the skeletal muscle to contract, and a monitoring method is used to record the action potential in the muscle, spinal cord, or muscle. As we mentioned earlier, the somatosensory evoked potential, and now we are talking about the motor evoked potential. These two technologies are complementary to each other. When using such technologies, we must use both of them at the same time, because our somatosensory evoked potential transmits an ascending conduction system, and the motor evoked potential is a descending conduction pathway. When combined together, the false positive rate is greatly reduced, and there will be corresponding cases later to see if this is the case. Then the methodology. We can stimulate at C1, C2, or C3, C4, C3, C4, which is about 2 centimeters in front of C3 and C4, and maybe everyone is familiar with these SA levels, which are very confusing and still can't do without what was mentioned earlier. We must understand the international 10 to 10 system of EEG and know where each position is and in which lobe each point is. And here, I'll share a little trick with you. When we usually do motor evoked potential monitoring, if we monitor both the upper and lower limb somatosensory and also monitor the motor evoked potential, when we stimulate, we find that the waveform of the motor evoked potential is very unstable. Here is a tip for you. We can set the recording points of the upper limb somatosensory evoked potential, C3 and C4, remove them, and then stimulate again. The waveform will generally be very stable, and it will be very good. Then for the upper limb motor evoked potential, we often record some muscles, such as the muscles on the upper limb, including the deltoid, biceps, denner, and hypothenar. For the lower limb, the main muscles we record include the quadriceps, anterior tibialis, soleus, and gastrocnemius. Sometimes there are some tips in our work. When recording some thicker muscles, such as the quadriceps, deltoid, and biceps, on inserting the needle, we can insert it a bit deeper, which might help produce better results. For areas like the vener, hypothenar, or the sole, the needle can be inserted shallower and still produce good results. The upper limbs are representative, with the vener and hypothenar muscles. The lower limbs include the sole and the anterior neck. These muscles produce clear evoked potentials in our exercise. The quadriceps and biceps may be influenced by anesthesia, making it difficult to obtain good waveforms. This is what we encountered during the operation. We stimulated at C1 and C2 and measured the activity of the denner and hypothenar and the sole of the foot. You can see that the waveforms are very beautiful. The third one is brainstem auditory evoked potential monitoring. Brainstem auditory evoked potential reflects the status of the auditory nerve and brainstem auditory conduction pathway. During the operation, it can monitor the functions of the auditory nerve and brainstem. It is one of the most commonly used monitoring technologies for the skull base. During the operation, this is a schematic diagram of brainstem auditory evoked potential conduction. First of all, we need to understand that these waveforms represent different waves. As we all know, the auditory nerve extends from the brainstem to the periphery. We need to know the significance of each wave. Generally, the E wave during and after surgery may produce 5 waveforms. During the operation, we mainly observe the first, third, and fifth waves. The E wave represents the auditory nerve, the third wave represents the superior olive nucleus, and the fifth wave represents the hypothalamus. We mainly focus on the status of these 3 waves. The records are made at the earlobe, A1, A2, or mastoid, M1, M2, because sometimes we do some posterior approach, such as the approach for resecting acoustic neuroma, which is usually performed through the retrosigmoid approach. At this time, the recorded electrode cannot be placed at a 1A2 as it will block the incision. We place it at M1, M2 in front of the ear, where the waveform of brainstem auditory evoked potential can also be recorded. BAEP is used to assess the functions of different levels of peripheral and brainstem hearing, including the levels of the auditory nerve, pons and midbrain. And the I wave is the intracranial part of the cochlea and auditory nerve. The second wave is the cochlear nucleus. The third wave is the superior olive nucleus. The fourth wave is the lateral lemniscus. The fifth wave is the inferior colliculus. And then, during the operation, we mainly observe the I wave, the third wave, and the fifth wave. The second and fourth waves basically don't need to be taken care of. Then there is the application during the operation, because BAP is easy to operate, has high characteristics, and is not affected by sleep or anesthesia, and can be repeatedly detected sustainably. If BAP changes during monitoring, we must first analyze whether it is caused by technical factors. The most common technical factor is the disappearance of the waveform caused by the total of the headset case or earplugs, because anyone who has done this job knows that, generally after anesthesia, before turning over, we will put the needle earplugs into his ears, because his earplugs are like a small cotton ball. Before putting it in, you have to twist it into a very small one and put it in his ear, but it will slowly swell up like cotton. It will expand, and it may be dragged out, and you can't see it when the sheet is laid. So before the sheet is laid, we must check the electrode needle, whether the earplugs are in place. These all need to be checked. If this happens during the operation, it will be difficult to operate. There are many things on it which will affect the operator. So these are the details of monitoring. For example, there is a drop in blood pressure, hypoxia, low temperature, and other physiological factors that will also cause changes in the brainstem auditory evoked potential. But at this time, the changes are bilateral, and it will not change unilaterally. Meanwhile, we monitor other items, and they will also change. If it is traction or separation, when the auditory nerve or brainstem is harassed, or some arteries or veins are harassed, affecting the blood supply to the auditory nerve and brainstem, it will not generally occur in bilateral changes, it will only occur in unilateral changes. At this time, we need to continuously monitor the changes in BAP and give timely alarms, which means that we need to do it more frequently. So sometimes, for example, when doing some decompression surgery, microvascular decompression surgery, we must monitor both sides. Some will not say, don't just because today's surgery is on the left. The right side will definitely not be affected. It is likely that the right side will not be affected, but at this time, if there are some changes, it can help us judge whether it is the vertical harassment of some of its nerve functions that cause changes, or because of blood pressure, hypoxia, low temperature, and other changes. The information provided to the surgeon is different, so we must monitor both sides at the same time in order to make a comparison and also help you judge what caused the decline. Then monitor the continuous change of the signal, which can predict nerve function damage. But when the signal does not change, it does not guarantee the integrity of brainstem function. So no matter what surgery we do, we will not only use one kind of monitoring. To complete this operation, we need to combine other monitoring technologies, such as MEP, and SAP, and then multimodal joint monitoring, to improve the sensitivity of evaluating brainstem function. The third point is that the intraoperative free EMG, which is the monitoring of free electromyography, and the electromyography monitoring, implants electrodes in specific muscles and records the electrical activity of the muscles to evaluate the nerve function that controls the muscle. Surgical manipulation or electrical stimulation can obtain the corresponding EMG signal, thereby preventing nerve damage. The electromyographic activity generated by free electromyography when the nerve is mechanically stretched can be used to reflect the stretching of the surgical nerve in real time and objectively, which is a commonly used monitoring item in neurosurgery and spinal surgery. Evoked electromyography is CMG, which refers to targeted electrical stimulation to our spinal or cranial nerves, causing the muscles innervated by the nerve to contract and generate an action potential, which is mainly used to find nerve block or to find the direction of a nerve, and is often used for CPA or skull-based tumors, spastic cerebral palsy, facial spasm, microvascular decompression, and then to assess whether pedicle screws penetrate the vertebral body cortex during spinal surgery, to identify whether the surgical tissue contains nerve fibers, and so on. So the monitoring of free electromyography is divided into two parts. One is free electromyography, and the other is the electrical activity generated by stimulation. This is our monitoring of free electromyography. You can see that when operating, the free electromyography will respond, and at this time, we must report to the operator in a timely manner. But here, I want to say, when we do neurosurgery, the bipolar will basically be used throughout the operation, but some teachers will ask, look, it's bipolar again, and the burning is all interference. Is this interference generated, or is it generated by traction or touching the nerve? Should we report this electrical activity to the surgeon? At this time, based on my work experience, if you're not sure, it's best to tell the surgeon, or if you really feel like it, let the surgeon put the stimulator on and check if there is a nerve response. This will help avoid nerve damage. However, monitoring too much is not necessary. The interference caused by the bipolar is different from that caused by pulling or touching the nerve and the electrical activity it emits. As you gain more experience in monitoring surgeries, you'll be able to distinguish between interference and nerve stimulation. The second point is that when we use electrical stimulation, if we're not sure which nerve it is and there's significant interference, we mustn't say that we keep it to ourselves. It's better to say something and place the stimulator to check if there are nerve fibers or structures nearby. Then we can be more assured. In neurosurgery, we often monitor cranial nerves. We know that there are 12 pairs of cranial nerves, but not every pair can be well monitored. Some cannot be monitored. The common cranial nerves include the oculomotor nerve. When there is a space-occupying lesion in the slope, the oculomotor nerve must be monitored, and the monitoring of the oculomotor nerve is also very technical, because if you insert the needle too deep and poke the patient's eye, or insert it too shallowly to record the normal response of the oculomotor nerve, it will be quite difficult to operate in practice. The trigeminal nerve, however, is easy to handle. Just place it on the masseter muscle. Basically, there won't be any problems. Regarding the facial nerve, we generally place two electrodes. One is to record on the orbicularis oculi, and the other is to record on the orbicularis oris, because sometimes when we are doing acoustic neurosurgery, the electrical activity on the orbicularis oculi may not necessarily be emitted by the facial nerve. If there is electromechanical electrical activity on the orbicularis oris, then we will clearly tell the surgeon that this is the facial nerve and the glossopharyngeal nerve. Unlike other conventional ones, we need a special electrode to monitor the glossopharyngeal nerve. This is the vagus nerve. It is placed on the cricothyroid muscle. The necessary nerve can be placed on the trapezius muscle. It can also be placed on the sternocleidomastoid muscle. Sometimes, during neurosurgery, the sternocleidomastoid muscle is likely to be penetrated. Then we can place it on the accessory nerve. The hypoglossal nerve is also commonly monitored in neurosurgery. Now, let's move on to some typical monitoring cases in neurosurgery and talk about them. The first one is known to all neurosurgeons. It is the clapping of carotid aneurysm. The patient is a woman who is 45 years old and has had intermittent headaches for 10 years. She was diagnosed with an intracranial aneurysm a month ago and has no other abnormal physical examination findings. The diagnosis is an aneurysm at the bifurcation of the right middle cerebral artery. Preoperative MRI suggests an intracranial aneurysm, and further CTA confirms an aneurysm at the bifurcation of the right middle cerebral artery. You can take a look at the image. There is an aneurysm at the bifurcation of the right middle cerebral artery. Now let's mainly talk about the monitoring methods. For this surgery, we used somatosensory evoked potential and brainstem auditory evoked potential monitoring. At the same time, we also monitored our EEG, and during monitoring, as we all know, we must do a baseline before anesthesia and before surgery to facilitate our later comparison. And then the images we do later are compared with the baseline. So at this time we need to hurry up and turn over. The first thing is to turn on your device, save the baseline first. And then, for this patient, we continuously monitor the SEEP and MEP, and everyone can take a look at the left side is our somatosensory evoked potential, and the right side is the motor evoked potential, and then at 12:40 NIC, we suddenly found that the left somatosensory evoked potential on the right side suddenly disappeared. There was no wave. At this time, we promptly at 12:41, we immediately did a motor evoked potential and found that the amplitude of the motor evoked potential also disappeared. At this time we don't hesitate for a second, quickly tell the surgeon, there is a situation, report to the surgeon, the somatosensory evoked potential decreased, the motor evoked potential also decreased. So at this time, why do we need somatosensory evoked potential and motor evoked potential to monitor at the same time, equivalent to monitoring these two techniques at the same time? Your false positives can basically be controlled within 3%, because as mentioned earlier, these monitoring techniques, our somatosensory evoked potential is to give it a stimulus in the peripheral nerve, and then through the posterior cord of the spinal cord, it is transmitted to our central nervous system. The motor evoked potential is to give a stimulus on the parietal tubercle of our bilateral brain, and then transmit it downwards. The somatosensory evoked potential is transmitted upwards, so the two complement each other. One transmits upwards, the other transmits downwards. Its false positive rate is greatly reduced. At this time, back to the operation, we promptly reminded the surgeon, and as everyone knows, aneurysm requires an aneurysm clip, and then adjusted in time, the position of the aneurysm clip. After timely adjustment, it took about 8 minutes. After the aneurysm clip was adjusted, you can see his somatosensory evoked potential, it recovered, and then after about 1 minute delay, our motor evoked potential also recovered. Just imagine, if this surgery did not have neurophysiological monitoring, after adjusting the aneurysm clip, the surgery probably lasted for about 2 to 3 hours. If we did not monitor, the aneurysm clip was always in that position, what would it eventually lead to? Ischemia, definitely ischemia, is a very important factor. After ischemia, the patient will definitely have problems with the muscle strength of the limbs. To put it bluntly, most patients will be paralyzed. Now, if the aneurysm surgery is solved, but it causes a series of neurological sequelae after surgery, then I think this surgery is also a failure. So after timely adjustment, on the first day after surgery, the muscle strength of the limbs is still poor, and the tension is normal, and then on the 6th day after surgery, the muscle strength of the limbs has recovered to level 5, and the tension is also normal. Then the second case is a common acoustic neuroma. Look at this 30-year-old patient. The complaint is a decrease in vision, accompanied by headaches for several days. The physical examination shows that the left eye vision is 0.1, the right eye vision is 0.3, and the hearing on the left side is significantly reduced. and the magnetic resonance imaging suggests that there is a cystic solid mass in the left CPA. This is an image of its magnetic resonance imaging. You can see that the tumor is still very large. And the monitoring plan we applied for this surgery is the first is our trigeminal nerve, then the facial nerve, then the accessory nerve, then at the same time monitored the brainstem auditory evoked potential. And these are some of the key points of our intraoperative monitoring. For this surgery, let me tell you a little story. A few years ago, a senior expert in acoustic neurosurgery in China, and our neurosurgeons should all know, Professor Yu Chunjiang from Sambo Brain Hospital of Capital Medical University, was one of the first in China to apply neurophysiological monitoring in acoustic neurosurgery, and I performed an acoustic neurosurgery with him at that time. We all know what we care most about in acoustic neurosurgery, saving the face. Because for acoustic neuroma, you might want to save hearing. Generally, for tumors larger than 2 centimeters, saving hearing is basically impossible, very difficult. So our main purpose is to save the face. At this time, after he opened it, we all know the first thing to be revealed must be the accessory nerve, and then he used a nerve stripper to probe the accessory nerve without asking if you had any reaction. He directly asked if you had facial nerve. At this time, you need to accurately tell him that you have facial paralysis. In fact, he is testing you. He said, "It's right that you have facial paralysis, because it's the accessory nerve that he is testing. Are you familiar with this technique?" This will determine whether he can trust you during the later surgery. You need to continue providing accurate information for this surgery, so we must pay attention to this matter. We need to solidly apply these techniques so that we can better help patients. Look at this time. After we go in. After we see the tumor, we will use the machine to check the walking path of the facial nerve. We need to figure out whether it is the facial nerve or the trigeminal nerve. The intensity of stimulation also matters. Generally, when we explore the facial nerve, we start from 0.1 millimeter and increase it gradually because we are in the brain and directly apply it to the nerve or some nerve fibers to stimulate it. So the stimulation intensity should not be too high at this time, generally no more than 0.5 millimeters. If you increase it, even if a response is stimulated, it may not necessarily be the response of the facial nerve. So we increase it by 0.1 millimeters each time to see if there is a response. If not, we increase it to 0.2 millimeters, 0.3 millimeters, 0.4 millimeters, and 0.5 millimeters. If there is still no response at 0.5 millimeters, we can't increase it any further. This is the patient's appearance before surgery. This is the patient's appearance 1 week after surgery. You can see that he has a bit of facial paralysis, but this kind of facial paralysis can basically recover. So as people's living standards improve, while removing the tumor, people also have very high requirements for appearance. For many neurosurgeons, removing a tumor may not be too difficult, but retaining the patient's neurofunction intact may still be somewhat challenging. But at this time, neurosurgeons and electrophysiological monitoring technicians must work closely together to achieve this goal. The third patient is also a case we have done many times. Facial spasm. The left side of the face twitches involuntarily for 12 years, and currently there is no facial paralysis and hearing loss. And the magnetic resonance also indicates that the root of the left facial nerve and the left vertebral artery and anterior inferior cerebellar artery are adjacent. You may have seen a lot of facial spasm in life, especially in Yunnan, which is relatively remote in China, and many patients in Yunnan said that this may not be a disease, and that left eye jumps for wealth, right eye jumps for disaster, left eye jumps means good things are coming, and right eye jumps means something bad is coming, which is not true. Many of these are diseases, and women are more likely to have them. Let's take a look at the patient's images. The vertebral artery is very thick and obvious. There's compression. Let's look at this patient. It's jumping even when not moving, right? Yes, it jumps without being induced. Has he undergone any previous tests? No. Has he received any treatment? This patient is under our surgery, and we are conducting an electromyography test. We all know that patients with hemifacial spasm have an important response, which is called the lateral spread response. During the operation, we will also monitor the lateral spread. This monitoring basically plays a decisive role in this operation because there is literature showing that without monitoring, the success rate of this operation is about 80%. If there is monitoring, the success rate of this operation can reach over 95%. What does this mean? This is the response of the electromyography. The right is on the left, and the left is on the right. You can see there is a discharge on the left, which is a unique waveform for patients with facial spasm. It is called the lateral spread response, and if you look at the right, it doesn't jump, so there is no response. If it jumps on the left, there is a response. The same is true during the operation. In our center, which is in Shiaheki town, we have given incentives and kept records in Yanwenzaji, which is what we just mentioned, the side diffusion reaction, and in Keji, we recorded a direct reaction. This is the situation in our count. Meanwhile, we also monitored brainstem auditory evoked potential, which is also very important in facial spasm surgery. For example, sometimes the surgical area will block the monitor, and some blood vessels will block the operation, but it is very important to know whether this blood vessel can be cut. For example, for some very small blood vessels, if you cut them, the brainstem auditory evoked potential will immediately decrease. The fifth wave will immediately decrease. Then the hearing will also be damaged after surgery. We have seen many such cases. So now, if that blood vessel is really blocking you, we have no choice but to press it first, and then do the brainstem auditory evoked potential. See if its waveform has decreased. See if it has an impact on it. If it is verified several times and its waveform does not decrease and it has no impact on it, then you can resolutely cut off that blood vessel. If there is an impact, then we can try to avoid it. Then do the decompression. Meanwhile, we also monitor free radicals. The monitoring of free radicals is to assist you to see if it is detaching from the facial nerve. Check the excitability of the facial nerve. Most importantly, I must talk about this. It is the monitoring of lateral spread. This is our monitoring of the orbicularis oculi. The recorded line is called lateral spread. You can see that before surgery, the waves of lateral spread are obvious. As the surgery goes on, the waves of lateral spread disappear, and the waves of orbicularis oculi represent that we have found the responsible vessel, indicating successful decompression. At this time, the electrophysiology can be connected to our microscope and monitored in real time. This helps you more accurately see what the operator is doing, and then combined with your monitoring, you can better report to the operator. The iPass I want to particularly emphasize. Sometimes I don't know about everyone, but in many centers I've seen, the stimulation intensity may basically start when the muscle relaxant is metabolized. Around 15 to 20 milliamperes of stimulation, or at most 30 milliamperes of stimulation, the sideward spreading waves can be well displayed. Throughout the entire surgical process, it is stimulated with 30 milliamperes. At this time, in 2023, we studied about 70 or 80 cases. Then in 2023, we also published a paper in Chinese about the guiding significance of stimulation intensity for hemifacial spasm surgery. We found that at 30 milliamperes, the side diffusion response continues to use 30 milliamperes after surgery. The side diffusion disappears and the surgery is over. Then, about 2/3 of the patients, he is still jumping. Why? Because it has been decompressed and the side diffusion has disappeared. At this time, there is another group of cases. We continue to increase the stimulation intensity. To what extent? Our maximum limit is 100 milliamperes. Now, after surgery, we usually reduce the stimulation intensity to see if it's fully sufficient. We need to increase the stimulation intensity to 100 milliamperes without causing the side diffusion response. Only then will we end the surgery. Otherwise, we won't stop, and we'll keep reducing the pressure. Some may ask, if the pressure has been reduced thoroughly, and it's shown on the MRI that it's compressing the artery, or the vein, sometimes some small perforating branches, some compression, cannot be seen on the MRI, but the side diffusion of electrophysiological monitoring is quite sensitive to that. As long as there is a little compression, the side diffusion still exists. So that's why we need to reduce the stimulation intensity until it reaches 100 milliampere without side diffusion, and we will turn it off when there is a response. But in some cases, there is another situation. As we all know, when we perform gastric vascular decompression, the surgical method is to separate the blood vessels and nerves with cotton. Sometimes, if there is too much cotton, the side diffusion response will always exist, and at this time, we need to remind the surgeon to see if we can take out some of the cotton and not stuff so much. The side diffusion disappears. If there is too much cotton, the side diffusion still exists. There will be a situation. Many patients have a word called delayed healing, which generally takes 2 to 3 months after surgery, and it is still jumping. But as time goes by, it will stop jumping. But at this time, although it is unlikely to jump later, in order not to cause some anxiety to the patient, we use a more accurate electrophysiological monitoring method, which can help the surgeon solve the problem at once. So the monitoring of facial spasm is also very particular about skills, and it is a very important method to cooperate with the surgeon. At this time, look at the next page of the image. Why do we use this electromyography monitoring? You can see that he is watering at this time, and the decompression is completed. His nerve excitability is very high. And at this time, if you stimulate the lateral spread, it will also cause great interference. Therefore, we monitor the free radical electricity at the same time, and when the free radical electricity is stable, we stimulate the lateral spread reaction, which can give you very accurate information. This is a complete image of our monitoring at the beginning of the operation. Just now, it was a local image. Before the operation started, we saw that this one was on the orbicularis oculi, and it recorded a little activity. In the middle, this is the electrical activity recorded on the orbicularis oris, and the last one is the electrical activity recorded on the platysma. Then the surgery began, and you can see that the three-way spread has always existed. You can see that at the beginning of the surgery, we used an intensity of 15 milliamperes, which has always existed until the release of cerebrospinal fluid. When monitoring the three-way spread, after the release of cerebrospinal fluid, the three-way spread disappeared, but at this time, we often increase the stimulation intensity, doubling or tripling it, and the lateral spread comes out again. If you do not increase the stimulation intensity and keep using the same stimulation intensity, the accuracy of your monitoring may be greatly reduced, because after the release of cerebrospinal fluid, the lateral spread may disappear, and you cannot monitor it later, which is equivalent to invalid monitoring. You can see that at this time, we continue to apply electricity until it is finished, and we keep using 100 millifarad stimulation until the end of the operation. You can see that there is no side diffusion. At this time, we can rest assured to end the operation. Then the monitoring area of side diffusion comes in. Anesthesia is also a very important group. Before the anesthesiologist performs anesthesia, if you are going to monitor the operation today, it is best to tell him to give it once during induction, and do not give long-acting muscle relaxant, because the long-acting one metabolizes very slowly, and the current facial spasm surgery is a keyhole surgery, which is as small as a coin behind the ear. Just make an incision and enter the body. At this time, if you use long-acting hormones, they will basically not be metabolized, and the accuracy of your monitoring will be greatly reduced. And you don't know whether it is the operator's operation in the front. The lateral spread disappears, or the lateral spread is metabolized by the depth of anesthesia and muscle relaxant, affecting the appearance of the lateral spread. At this time, you cannot accurately provide monitoring information to the operator. Therefore, before monitoring, we must fully communicate with the anesthesiologist. Use short-acting muscle relaxants, not long-acting ones. Moreover, use it once during intubation induction, and never add it again later. Otherwise, the monitoring cannot be done. The fourth case is now the popular hemiplegia in recent years after cerebral hemorrhage or cerebral infarction. Hemiplegia on one side of the body, high muscle tone, pain, and in recent years we have been doing popular surgeries such as neuromodulation surgery, spinal cord electrical stimulation surgery, and the patient's symptoms are shown here.
Is there any difficulty? The feet drag on the ground and cannot be lifted. Did you suffer an injury after cerebral hemorrhage or cerebral infarction?
This patient had a cerebral hemorrhage followed by paralysis of the right limb, which is commonly known as carrying a basket hand and walking in circles. His fingers were clenched and his muscle tone was high. With these symptoms, our electrophysiological monitoring plan is that during the surgery, we place 2 electrodes in the cervical and lumbar enlargement areas to stimulate the spinal cord and reactivate the neural conduction pathway, thereby changing his muscle tone and alleviating his pain. At this time, we monitor the upper limbs. Generally, we monitor the deltoid, biceps, and the quadriceps and anterior tibialis of the lower limbs. We also monitor the sole and perform motor evoked potential monitoring. This is to ensure that the spinal cord function is not damaged because it is a surgery on the spinal cord. Although it is epidural, we also monitor motor evoked potential and somatosensory evoked potential. It's a matter of convenience to monitor its electromechanical status. Let's take a look at the spinal cord electrical stimulation published last year. It's the Chinese expert consensus on treating stroke-induced hemiplegia. Regarding intraoperative electrophysiological monitoring, it's a crucial step for the success of spinal cord electrical stimulation surgery. It can provide real-time and objective electrophysiological feedback, fundamentally enhancing the accuracy, safety, and effectiveness of the surgery. It serves as a key bridge connecting surgical procedures and post-operative outcomes. The guideline clearly states that it mainly manifests in 4 core functions. The first one is to achieve functional localization. It ensures precise electrode implantation. How should I put it? While performing the surgery, we check if the electrode is correctly placed. Once we confirm that, the surgery is completed, but the electrode position being in the middle doesn't mean it functions in the middle. As we all know, patients with stroke-induced hemiplegia often stay in bed for a long time and experience hemiplegia on one side of the body. They walk with the same posture for a long time, which may cause some spinal curvature. So, in terms of monitoring, the core importance of electrophysiological monitoring comes into play. Through monitoring, we can ensure the electrodes are accurately implanted into the target spinal segment. During intraoperative electrical stimulation, we record the electrical signals generated by specific muscles. This directly verifies whether the electrical stimulation successfully activates the target neural pathway. This is a significant leapfrog over anatomical localization based on images, achieving functional localization. This ensures that electrical stimulation precisely targets the lesion segment, laying a solid foundation for good post-operative outcomes. Currently, before surgery, we use CT to pinpoint the segment, and during surgery, we can avoid using the C-arm as it is time-consuming and exposes us to radiation. In such cases, electrophysiology can help validate the functional positioning is intact. Its second core role is as a safety radar. It safeguards the nerves in real time. Given the limited space within the spinal canal and the delicate nature of the spinal cord nerves, we monitor both the electromyography and evoked potentials. If abnormal electrical signals are detected, we intervene promptly to prevent nerve damage. This greatly enhances the safety of the surgery. For stroke patients who already have neurological deficits, further damage would be detrimental. Thirdly, we provide successful templates and post-operative outcomes. As everyone knows, this surgery is a neuroregulation procedure. It involves spinal cord electrical stimulation. Real-time monitoring during the operation provides effective evidence for successful surgery. During the operation, we use different contact combinations to power it on. We see which combinations have a more obvious effect on reducing muscle tone and alleviating pain, and then use these parameters for successful control after the operation. Without monitoring, we can only communicate with the patient slowly, let him feel for 2 or 3 days, and then gradually control it. If we have monitoring, we can do it in one step. These few contacts have a good response to the target muscle of his nerve. We can use these parameters to control it, which greatly shortens the patient's length of stay, and also precisely stimulates his target muscle, saving the patient a lot of money. The fourth core role is to promote the standardization of surgery, and to promote the homogenization of this technology, and the guidelines clearly mentioned, recommending the use of monitoring, because it marks the SCS surgery, which relies on personal experience, to a programmed operation based on objective evidence, and the application of monitoring reduces different doctors, and the differences in the operations of different doctors and different centers, and then promotes the standardized and homogenized development of SCS treatment nationwide, allowing more patients to enjoy this cutting-edge technology. In short, it is to monitor and assist in the examination of AF. It is the core navigation and safety guarantee system in our neuromodulation surgery, making invisible neurofunctions visible, and it is the core requirement for us to ensure the accuracy, safety, and effectiveness of the surgery, and ultimately achieve the goal of patient functional reconstruction. This is also clearly stated in the guidelines. Some of the monitoring methods we use, I've already explained in detail to everyone, and here's what needs to be noted. For some hemiplegic patients with muscle strength less than level 3, the monitoring effect may not be so good. So you need to clearly check the muscle strength before surgery, and roughly which limb is at what level, to help you make a better judgment during the operation. Finally, let's talk about what happened in 2024. It also served as a wake-up call in our circle. A large top 3 hospital did not use electrophysiological monitoring, resulting in paralysis of the limbs. You can see that. At that time, the law stated that large top 3 hospitals represent the highest medical level in the local area. They have a lower tolerance for errors. Similarly, in the judicial appraisal of medical malpractice, the requirements for different medical institutions are different. Therefore, the final medical malpractice was not discussed during preoperative discussions on spinal cord injury, and nerve electrophysiological monitoring was not used. These errors led to a compensation of over 500,000 yuan. Another case occurred last year, also during a thoracic surgery, resulting in paraplegia. This case involves medical malpractice and compensation. Initially, we suffered some losses due to these incidents. So now, for certain surgeries, we must use nerve electrophysiology. For thoracic surgery, the guidelines for thoracic spinal stenosis diagnosis and treatment, and the key points of electrophysiological monitoring in spinal surgery clearly recommend continuous electrophysiological monitoring for such surgeries to avoid intraoperative spinal cord injury. This is not only to protect yourself, but also to protect the patient. Overall, it does not cause much trauma to the patient. It has no drawbacks, only benefits. Therefore, we still recommend the implementation of these spinal surgeries or other surgeries to use electrophysiological monitoring because in Yunnan, our electrophysiological monitoring technology compared with Beijing, Shanghai, and Guangzhou is still in a relatively backward stage. Maybe everyone doesn't pay much attention to it. And some are just monitoring for the sake of monitoring. One person runs 2 or 3 operating rooms, which is actually just monitoring for the sake of monitoring. You don't achieve effective monitoring, and you don't know what's happening in real time. Therefore, to do this job well, we still need full-time personnel to follow the surgery and do a good job in monitoring. Finally, to summarize, monitoring requires teamwork and mutual trust. As mentioned earlier, how to cooperate and trust each other. The first point is effective monitoring. This concept is very important. In Yunnan, many of our units have monitoring equipment, but it has been gathering dust for years. It's not really being used. Even if it is used, to put it bluntly, it's just collecting fees or doing something like that. So we must achieve effective monitoring. Which can truly help surgeons improve their surgical skills and is a very important means. The second is the cooperation with anesthesiologists. As we mentioned earlier, when we are monitoring, we need to communicate well with anesthesiologists. How to monitor, what cannot be used, what monitoring cannot be used. For example, the side diffusion mentioned earlier requires short-acting muscle relaxants, and when monitoring somatosensory and motor, a muscle relaxant is used during induction and then never used again. Then, for inhalation, try to keep it below 0.5, which can ensure better monitoring. The third point is cooperation with the surgeon, because we all know that monitoring is not a one-person job. You can't just do it by yourself. You need to cooperate well with the anesthesiologist. Second, it's more important to cooperate with the surgeon. Give him real-time feedback to reduce unnecessary operations. This is what a complete and mature team should do. That's all for today's lesson. There may be many shortcomings. Your criticism is welcome. Thank you.
Well, Dr. Su-Jing Cheng, your lecture was wonderful, but good times never last long. Su-Jing Cheng explained the principles of fixed body separation, development history, application scope, and clinical cases, sharing his personal clinical experience.
I would like to interview Director Yang. With Mr. Su-Jing Cheng's assistance in your surgery, or in your experience, is it better or very good? Do you have anything else to add?
It's very good. A couple of days ago, I did electrohydropathic stimulation. He immediately pointed out to me, when I put on the electrode, he asked, "What is this, Sue?" I stopped immediately. Then I adjusted the direction of the electrode and put it in place at once. There was no obvious stimulation of the nerve root. This is very important. Otherwise, if I push it in further, it may damage the nerve root. That would be even worse. So I can't do surgery without electrophysiology, except for simple cerebral hemorrhage.
I also feel that Teacher Sue's monitoring is very solid. As Teacher Sue said, the accuracy of the alarm, I think 95% is definitely underestimated, and the experience is also very rich. Now it comes to the next session, the interactive session, our wonderful Q&A. Everyone can start leaving messages now. and we will answer all the messages on all platforms. Let's get into the first question. Finally, let me start with the last question. When we monitor SCS, will using motor evoked potentials damage the SCS battery?
When we finish SES, the battery is in a temporary stimulation state when it's turned on, and it won't damage the battery, so it has no impact. But for SES, basically after we place the electrodes, we give it a stimulation before placing the battery to see if its motor function is intact, and then we connect the battery to see if its target muscle responds. So basically, the battery is not involved, and it won't be damaged.
Okay. So basically, for SCS, when using motor evoked potential monitoring and SCS, they are not carried out simultaneously.
So there is no conflict.
Right. And the next question is, when you were talking about lateral spread, a teacher asked, during the process of lateral spread, the abnormal waves repeatedly disappear and reappear. What is the reason?
This is what was just mentioned, the stimulation intensity. You can take a look. There is a paper published in Chinese in 2023 about this stimulation intensity and its guiding significance for surgery. It disappeared and then reappeared, which may ultimately be due to incomplete decompression. Sometimes the cotton wool may be peeled off with cellophane, picked up and then put back, or other operations are performed along with the surgery, such as hemostasis or other operations, or too much cotton wool is placed, which still causes irritation, so it appears and disappears. At this time, we need to carefully explore again. Increase the stimulation intensity. If he feels that he has been fully decompressed and there is nothing to shock, then increase the stimulation intensity. As I said earlier, it can be increased to 100 millimeters, but when it is increased to 100 millimeters, the line will be very floating, and the skill of acupuncture at this time is relatively deeper. If it is increased to 100 millimeters, then in the final analysis, it is still not enough decompression. Then we have to find if there are any other branches and whether there is still compression.
Okay. For the whole surgery, Director Yang did a very delicate job. I would like to ask, you just mentioned that the requirement for the skill of acupuncture is very high. What should be paid attention to in acupuncture?
In our center for hemifacial spasm, we only stimulate the marginal branch of the mandible, and then in the orbicularis oculi, we record the lateral spread. For example, if the patient has insufficient acupuncture, after the patient turns over, the needle will move, and you will not be able to see the manifestation of lateral spread. And in work, we may encounter some very fat patients. After they turn over, a lot of flesh will pile up on their neck. At this time, when we give acupuncture, we need to insert the needle a little deeper, which can better record the lateral spread. For some relatively thin patients, we should not insert too deeply at the mandibular notch. If you feel that you have reached the bone or the needle is too shallow, when the stimulation intensity is very low, the spread of the line is very good looking, but when you increase the stimulation intensity, the spread will float away and you will not be able to see it at this time. So after monitoring more, you will know how to do the surgery according to the patient's body type, the thickness of the flesh on the face, and so on. If the patient is fat, how much should the degree of liposuction be? If the patient is thin, how much should the degree of liposuction be?
There is no specific research, but it is based on the patient's body type to ensure that the side diffusion always maintains a good waveform. The next question is, when doing somatosensory evoked potential, will the stimulation of positive and negative poles affect the waveform?
Yes, it will definitely affect it. Think about it. The negative pole is used for stimulation, and the positive pole is used as a reference. When we do somatosensory evoked potential, we give it a stimulation on its periphery. If you reverse it, won't the stimulation go outside, to your fingers, If you stick it in reverse and the negative pole is attached to the eye-heart end, then there will be no recording outside. How can you show the waveform of the somatosensory evoked potential at this point? So this must not be reversed. Then you think about it in reverse. If you don't press the reverse, the negative pole serves as stimulation, and the positive pole serves as a reference. After the negative pole emits electricity, it can travel through our body's periphery, nerve roots, and central nervous system for transmission. This is what I usually tell other teachers who come to our unit for further study. They think that this way of understanding might be understood immediately.
After listening to Mr. Su's explanation, I think it's very vivid. He said that if it's passed it on the wrong side, the direction of the stimulating current will be like the direction of our fingers, and then to the distal end, it is equivalent to the current needs to be folded back and then conduct upward along our limbs. Overall, we definitely hope to use the cathode to stimulate the proximal end. But when we do the somatosensory evoked potential, the positive and negative poles are reversed, which should not greatly affect the phase of its waveform, and it can still be done.
Yes.
Of course, we will follow Professor Su's advice. Everyone should try not to reverse it. And there is one last question. Why does the free electromyography of the orbicularis oculi not necessarily be emitted by the facial nerve, as you mentioned during the surgery and throughout the lecture? You mentioned that you attach great importance to the waveform of the orbicularis oris, but the waveform of the orbicularis oculi may not necessarily be a specific wave of the facial nerve.
Yes, as mentioned earlier, when performing acoustic neuroma surgery, the facial nerve branches on the orbicularis oculi, based on our experience, have been verified to emerge independently at this time. If they appear on both the orbicularis oculi and masseter, we don't complain but report trigeminal neuralgia. Then, after verification during the operation, when we use the stimulator to trigger, it indeed triggers the trigeminal. If orbicularis oculi and oral Rinzagi appear at the same time, we report facial paralysis with a very high accuracy rate.
Okay, learned something new. Thank you very much.
It's quite profound.
Yes. There are many questions below, and the next question is how to monitor the trigeminal nerve. Besides the masseter muscle, which other muscles should be monitored?
The monitoring of the trigeminal nerve is not like the monitoring of facial spasm, which has a clear guiding significance to see whether the decompression is sufficient. For the trigeminal nerve, we mainly need to monitor its brainstem because the trigeminal nerve is prone to damage after decompression. Trigeminal nerve damage can easily lead to hearing damage. We mainly monitor the brainstem, and for the cranial nerves, we usually place the trigeminal and facial nerves. We also place the accessory nerve. When operating on patients, I need to know in real time which nerve it is so that it can play its role. But the most important thing is to monitor the brainstem because hearing loss is its biggest complication.
Do you have anything to add, Director Yang?
No. He mentioned the brainstem, and I asked him to elaborate. Which functions of the brainstem should be tested?
Evoked potentials, including the brainstem auditory evoked potential, BSP.
Okay. Next question. Are there any patients with hemifacial spasm who cannot record the lateral spread wave during surgery?
At the beginning, now, basically in our unit, there are no patients who cannot record the lateral spread wave. At this time, it is very important to use short-acting muscle relaxants. Long-acting muscle relaxants cannot be used. Even if you use long-acting muscle relaxants during the operation, you should communicate with the anesthesiologist and ask him to use antagonists. But the effect is not good because it takes a long time to metabolize. The facial nerve decompression surgery is a small hole as small as a coin through which we can see everything. So short-acting anesthesia is used for induction and then not used anymore. This is the main reason. The second reason is that the needle is not inserted properly, which also leads to no waves. Another situation
is that in the early stage of facial spasm, patients don't know they can undergo decompression surgery. They receive botulinum toxin injections. If they have received many injections or within the last 3 months, and then they get the surgery, we need to increase the stimulation so that the wave can be detected, but it will be very low.
That's all. Next question from one of our teachers. You just mentioned the electromyography of orbicularis oculi and the electromyography of trigeminal nerve. He added a question that multiple pairs of needle electrodes need to be placed on the same muscle to collect samples from multiple muscles innervated by the same nerve.
No. I didn't quite understand this part.
I think his question is, you just said that monitoring the facial nerve requires orbicularis oculi, orbicularis oris, and mentalis. So does it require sampling from multiple muscles innervated by the same nerve? If it's the same muscle, do we need to place multiple pairs of needle electrodes for sampling? It should be such a question. Kyle, could you add something? Is it the same teacher who asked the question? Let me take a look. This should be the live streaming platform of Shenhukishin. Okay, I entered the live streaming platform. No, it's not the same teacher. I think it should be like this. You can answer in this direction first. Our online teachers can add more. I'll go to the Shenhukishin platform to take a look.
This is about the muscles being controlled by different nerves. Based on our work experience, it is not necessary. Basically, during the acoustic neuroma surgery, monitoring the orbicularis oculi, orbicularis oris, and abdominal muscles, and these few muscles can basically meet the needs and ensure good facial appearance, as long as you cooperate well with the surgeon.
Okay. The next question is still about the facial nerve. It is said that the MEP waveform can determine the damage of the facial nerve and trigeminal nerve. Can it predict whether there will be facial paralysis after surgery?
Yes. For example, after the surgery, we usually do the acoustic neuroma surgery and then give it a stimulation, which means that if you can still stimulate the facial nerve response within 0.5 milliamperes, then there will probably not be much facial paralysis. If there is no response to stimulation, and the stimulation intensity is around 0.5 or 0.6, and there is still no response, then there is a high chance of facial paralysis.
Yes, two monitoring methods can be used to determine this. One is the trigger EMG just mentioned by Professor Su, which uses small current to stimulate and determine whether the facial nerve is damaged. Another way is to use facial MEP to do the facial nerve motor evoked potential. The effect is also very obvious, but the voltage needs to be smaller, maybe between 50 volts and 80 volts. Yes, both ways are possible.
Also, when he splashes water, you can see if there is a series of reactions in the facial nerve activities. If there is no reaction, it is probably damaged.
Okay. The next question is, for acoustic neuroma, should we use a bipolar probe or a single probe to stimulate?
We use a spherical probe.
A single pole spherical probe.
We don't use the bifurcated one. We use the spherical one.
Why? What? What's your consideration?
When making the spherical probe, we know that it is smaller, and I think it should be more accurate, because for children with cerebral palsy, when doing surgery such as cutting the spinal nerve root or dividing them, using a double fork might work better, because using a spherical head when performing the CPA surgery during the acoustic neuroma surgery, it is not necessary to directly pierce the nerve. It might be more convenient to stimulate the surrounding tissues repeatedly. It is not directly aimed at the nerve.
Where's the anode placed, sir?
The spherical anode is placed vertically during the operation. It determines the surrounding area where nerves run or where nerve fibers are present.
Okay. For acoustic neuroma, monopolar probes, concentric probes, and bipolar probes are used by experts nationwide. They believe that with low energy, as mentioned by Professor Su, 0.1 millimeter or 0.01 to 0.05 millimeter, the current diffusion has little impact on nerve determination. So, single-ended, double-pronged, or concentric electrodes can all be used. As Professor Su mentioned, the double-pronged one may be a bit inconvenient to use, and it may be inconvenient to stimulate the nerve. The biggest difference between monopolar and bipolar electrodes is that for bipolar electrodes, the distance between the anode and cathode is 0.5 centimeters, so its stimulation range is very limited. The spread is relatively small. For monopolar probes, the distance between the cathode and anode is slightly longer, so it is more helpful for nerve detection. With the increase of current, it is helpful for nerve detection, so you can use the current to assist you in using the probe. Both monopolar and bipolar probes are now used nationwide, and the effects are relatively reliable. Let me see if anyone has any more questions. I don't know if our overseas experts have any questions. Hello. Distinguished experts, do you have any questions? Let's take a look at our domestic colleagues. Do the experts have any questions? It's already 8:33. And Director Yang is on emergency duty. If there are no more questions, we won't prolong the time today. Thank you very much to all the experts. And thank you to all the teachers for participating. At the end of this meeting, I'd like to introduce our company, Shenhiwo Kishin, which mainly provides professional online and offline intraoperative neuromonitoring training, because intraoperative neuromonitoring is a very niche field and there are very few experts as professional as Mr. Su. So we are appealing here. Our experts can register on our Shenhu Kishin app, and when other experts in other hospitals need it, we can provide support. For hospitals that still have difficulties in electrophysiology, we hope that through our magical app, they can publish demands and then see if they need online training or offline one-on-one training. And the right side is our app. Welcome everyone to scan the code to register. Whether you are the demand side or the demand side, we welcome you to join us. The login method of our app is quite simple. You can directly search for Shenhu Kishin in our WeChat official account. The fourth character is different from the one in the idiom. The first Den means guardian deity, and the second Shen means nerves. We hope our intraoperative electrophysiological monitoring can protect nerves like a guardian deity. That's why we named it so. The logo has a pair of wings on it, representing our angels in white. The last stroke of the character Shen links to a neuron, hoping to protect our nerves like a guardian deity. That's the introduction to the app. If you want to become an EP doctor, registration is required. It's a real name registration. The app also has location positioning, which you can see in your province and city. We hope you can upload your medical records and introduce yourself. Special thanks to Director Yang for your support. Director Yang, could you say a few words?
About this platform, it's doing great. It would be best if everyone could promote it here, because for surgeons, it offers an extra safeguard, another layer of security, and a tool to verify your surgical skills. Well, thank you, Mr. Liu, for your amazing creation of such a platform.
I also want to thank Director Yang and Professor Su for their generous help. Finally, I have a few more questions. Let's discuss them offline. This opportunity is rare, so could you please answer one more question? I'm afraid I won't be able to reach this person. He wants to ask about the response of the facial nerve and trigeminal nerve during irrigation. When the MEP is at 100 microvolts, it can be normally elicited or with mild facial paralysis. Is this normal? There is a response from the facial and trigeminal nerves during irrigation. Is it normal for the MEP to be normally elicited or with mild facial paralysis at 100 volts?
He said that 100 volts should be its sensitivity. He didn't say its intensity of stimulation, right?
I think he meant that it can be normally elicited under the stimulation of 100 volts.
Oh, so it's about voltage stimulation. It responds when irrigated, maybe like the case we just mentioned. You can see that the tumor is quite large, and it responds when irrigated. It also responds to 100 volts of stimulation. There's still facial paralysis, but generally, after 2 to 3 months, you can basically recover. It doesn't mean that if there is a response to stimulation or irrigation, there is no facial paralysis at all. Generally, for acoustic neuromas, especially those larger than 2 centimeters, there may be mild facial paralysis, but this will mostly recover, not completely damaged. It's rare for it to not recover.
Okay, Director Yang, sorry about that. It's a rare opportunity. Thank you all for participating. And that's the end of today's salon.
Special thanks for creating some learning opportunities.
Yes, Director Yang, really. Okay,
Thank you for your tolerance.
I'll go down now.
okay, Director Yang, you go first. Okay, goodbye, everyone. See you next time. Hope everyone will actively participate in our lectures. Okay, goodbye, Director Yang. Goodbye, Teacher Sue.
Goodbye, Minghui.
Goodbye.